Whenever you guys are ready.
Perfect. So I can start. Welcome, everyone. This is how to succeed on your internal medicine clerkship. We can go to the next slide. So this is some information about us. Maybe each one of us can introduce ourselves.
Well, thank you so much, Dr. Frias. My name is Ricardo Correa. I am an endocrinologist by training, and I'm the actual program director for the Endocrinology, Diabetes, and Metabolism Fellowship at the University of Arizona in Phoenix, and the director for diversity and graduate medical education.
I am Rosa Frias. I am a PGY1 at University of Miami Jackson Memorial Hospital.
I'm gonna hop in only because I had the ED slow, but I'm Victor Rodriguez. I'm a PGY2. I'm a med psych resident. If you guys have ever heard of combined training, I do both.
Hey, my name is Joseph Rojo. I'm an M4, and I am actually an EM student, but was a really fun time. So overview of, oh yeah, you can go next. Is Alex here?
Yeah, I'm here.
Oh, Alexander, sorry.
Oh, sorry.
Yeah. Okay, I mean, I'll go until he pops in. So overview of the internal medicine rotation. Internal medicine is really your main opportunity to become familiar with the common and acute chronic illnesses that patients face. And most importantly, really to solidify your basic clinical skills and develop a strong base for communication through presentations as well as charting and talking to your patients. The typical format is, either fully inpatient or inpatient with some outpatient, but it's mostly just a lot of inpatient. And things to be aware of. I see the most important thing for your internal medicine rotation is to develop organization and consistency, developing a systematic way to approaching your patients with everything you do. So with your pre-rounding, with your notes, with your presentations, just being consistent every single time until usually you get to a point where you have developed the skills where you can branch away from that consistent pattern. And the other biggest thing is you're your patient's advocate. Given the amount of patients your residents will be taking on, you will spend the most direct time with your specific patients, and so you should know the most about them. You can go to the next slide. So in your general overview in daily life, so typically you'll start with pre-rounds, and you'll want to discuss with your resident whether you pre-round on your own or whether you go with them to go see your patient when you go see them. And there are many ways to approach pre-rounding. In my experience, what I found really helpful is, again, developing a systematic way to approach it. So you want to review what happened since you left yesterday, what were the overnight events, new labs and imaging that came in. And then once you kind of have that subjective piece of what happened, then you want to start developing your objective piece of what's happening. And so you want to go see your patient, seeing how they're doing, see what their concerns are for the day, and putting together your thoughts on what the plan is for the day and discussing that with your resident. I think the biggest thing to think about as you enter your internal medicine rotation is why is my patient still here today, and like how can I get them closer to either getting better or going home. And so after pre-rounds, then you'll round, which there isn't a lot to say about rounds. They're either the longest part of your day or they're very short. It's very attending specific. So talk to your residents about that. And after rounds is when you'll get your work done. You'll do your notes, you'll do your consults, you'll do your follow-ups. You may have like lunch didactics or noon meetings. And typically then in the afternoon, you'll run the list to see what have you done today and what do you have yet still to do. And then you'll wrap up for the day and kind of think about what you're gonna do tomorrow. Perfect, yeah, you can go next.
I'm not sure Alex is here, right?
No, I think that he sent an email saying
yeah. So he wasn't unable to join you, sorry, but maybe if we have time in the end, we can go over his individual experience since he's not here, maybe. We can go to the next one. Yeah, so I can talk a bit about my own experience. So I went to medical school in Puerto Rico, San Juan Bautista School of Medicine. And internal medicine was my first clerkship of their year that usually, since it's one of the longest and it's one also known as one of the hardest, then it's a bit overwhelming. And in my case, I like to be very transparent whenever I talk to students. So I didn't pass the step 1, and I found out about that on my 3rd week of my internal medicine rotation. So obviously that was very overwhelming on its own. However, I was like, well, I have to finish this rotation, even if it's long, hard, whatever, and kind of like channel and focus on the task that I had at hand. So eventually I was able, to pass the shelf exam well, and I passed my class, just the rotation overall very well. And I got like very good feedback from all the attendings that I work with. So challenging, probably initially finding that systematic way of approaching every day in a way that it was time efficient. I would say that probably what I like the most is the continuity of care, that you actually get to see what happens to the patients once they actually, at least for the most part, you try to figure it out, at least send them home in a way that they are like stable. And what I dislike is that, so you have to be very early, and since it was my first rotation, it was like a huge adjustment initially, but getting there like 4:35 in the morning sometimes, just to make sure, because my attending in particular passed round super early. So that's just one thing. How I prepare, since I had reviewed the step 1 material, like very recently before this one, then I feel like that helped, even though it didn't help for the exam as much initially, but definitely helped for the rotation. The attendings and the residents, so everyone is different. Everyone has his own style. Some were more like old school, others rounded for like 3 hours, others rounded for like 30 minutes. So it just all attending dependent, and the residents in general were like very willing to teach and like meet you where you were, which I liked. I didn't have any preconceived ideas of like stereotype of internal medicine, but I can say that the internists, especially internists, they do work a lot. And patient populations, mostly adults, mostly elderly, and very few young adults, at least in the population that I had.
Could I use your template kind of to give, I guess, we'll go up in years since you're an attending now. I'm a PGY2. So for me, my, I guess I can give both like evaluator as a resident plus what I remember from med school. So I did my rotation at the very end. And it's really weird because I feel like at least some of the med students I have, I like compared to how I did, because I was like, dang, was I a lazy med student in some cases? But no, like y'all do what y'all need to do. But definitely like as an intern, like you come in and there's so many things that are coming at you that you're like kind of frazzled about what you're doing. That knowledge base, know that you have just as good knowledge base as your intern sometimes. So like any way that you can help out is great. Any little input is great. If you want to help them out with their note, like when you're taking history and all that, it's super beneficial. Like I had one busy day that I still remember, like I gave this med student like raving reviews because I came back and she had like finished 4 of my notes and she was only doing 1, like she was only following 1 of my patients. And I was like, I don't know how you found time. I'm over here like drowning. But definitely like as an intern, like you'll be helping them out a lot. If it's just like the small little things that you kind of help them out with, like go a long way, and they'll definitely like enjoy it a lot. Preparation for me, all I really did was UWorld when I was in med school. And because it was my last rotation, what really helped is that I had already kind of touched on a little bit of everything. So it's kind of like refresher. So it was very helpful for me. And then attendings and residents, I think my med school, I really enjoyed it. It was really great. And then here, I hope that I've been I've been like, having a good time with my med students. I try to like once everything's done, I'm like, peace out, go study, because that's what's important to you guys. Yes, clinical is great and all, but also you have to pass your test. So like I try to make people leave as early as they can when they can. And my population, I think that's kind of, I actually wanted to do family med. I'm actually med psych because of kind of what I want to do, because I still want to have kids. I sadly don't. But it's kind of that I hit the same like young adult to adult population. And then one thing that I just thought about, you guys are really important. And this is like my psych component here, is sometimes either residents or whatever the case may be, you're too busy, they don't have time to talk with your patient. You have that time with the patient. Get as much as you can from that patient. I've had too many, like, I've had random patients that leave AMA and all it was is because they were homeless and we were putting them NPO. And so he freaked out and was like, oh, I can't, like, it was a stressor for him to be NPO. And so I just told him, hey, if I give you double portions next time, are you willing to stay? And he did. And there was like another patient that had like another kind of like similar story where it's like, just by talking to them, you learn so much. Like you don't use the word non-compliant, it's the non-adherence, and you have to figure out why are they non-adherent, like what is going on. So that's just like my little spiel, and I think you guys have time to do that.
Yeah. Well, I will not add a lot of difference between what Dr. Frias and Dr. Rodriguez mentioned, but just several things. One is that I'm the grandpa here. I did this rotation 14 years ago. So I coming from an old experience, but I think that probably it keeps the same. And definitely another bias that I had is that since I was probably 13 years old, I knew that I wanted to become an endocrinologist. And I had passion for internal medicine. So I can tell you that probably internal medicine is really what the science behind medicine is, and it's where you will find every single interesting thing. Of course, if you look at it, if you don't look at it, you will find that this is job. But if you look at it, you will find that in internal medicine, there is everything under the sun. And really, it's very, very important to learn basic concepts when you are in internal medicine, because that will help you to every other specialty. Because if you think about chronic conditions, the internists are the ones that are following. And you will see chronic condition in surgery, in OBGYN, in other areas. So learning that, it's very important. And I will tell you a little story at the end, why I think that focusing on those in the clerkship of internal medicine is one of the most important things that you can do in your medical school. Because, well, I will tell you the story at the end. So what is the rotation looks like? Definitely, I think that Dr. Rodriguez mentioned this, arriving early, leaving late, supporting your interns and your residents, being very active. The only way to learn in medicine is doing it. So if you hear it, probably you will not learn it. If you do it yourself, you will learn it. I think that the challenging part is that in medicine, we don't have a specific thing. Like, I know surgery, you have a tumor, and then in the tumor, you just go and remove it. That's the job of the surgeon. That's it. Go remove the tumor. What is the job of the internal medicine is, okay, what tumor is causing it? It's having production, not production, what I can do. So all of the other things, and then you get a list of differential diagnosis, very long, that you have to do that. That's why I think that it's like a CSI. Like, you don't know what the patient have, and yet you're just investigating what the patient have. What you can use for preparation, I think, is that the basic concept of step one, now that is very clinical step one, it's important. If you have time, there is the Bible of internal medicine that is called the Harrison book, where if you have time, it's a big book, but if you have time to read the topics that you have more important, it's good. Also, if you have the opportunity to get UpToDate or Dynamet, those are very good sources to have a background check, and also what is the latest evidence that is there. What is attendance and residence as any other area. I think that in internal medicine and pediatrics, probably they're more friendly than in surgery, but you will find attendings that will be very mean with you, and supposedly they should not be, but they can be mean. And then you will find attendings that are so approachable and that want to teach you more and more and more. And definitely, I think that the stereotype that always everybody has about internal medicine is that you just think and never have an answer. And that's not true. We really find the answer, but it takes us more time. We cannot do it in one time. And the patient population is adults. Sometimes you can use adolescents because they're very similar. If you combine it with peds, then you can have both. And then there is a big population that is growing in the United States, that is the geriatric population, and that's internal medicine. So we see a lot of older population. I see a lot of older transgender population that is so important that in the past there nobody were seeing. So that's something. The thing that I wanted to mention why it's so important is I remember when I was an intern, the first consult, well, one day at 2 a.m., an orthopedics resident in Miami. So I did my residency in Miami. So an orthopedic residency called me and say, hey, I have a patient that the blood sugar is 200 and something. A diabetic patient, the blood sugar is 200 and something. I need a consult with internal medicine. And I said, like, well, did you already restart the medication of the patient that was at home? What are the medication? The person didn't know what medication they were taking. They didn't restart the medication. They said, and I just got mad with that resident. I remember fighting. I was no, I was not an intern. I was a third year resident. I was just fighting with that resident because I said, the final thing I say, did you went to medical school? Because diabetes is in every single topic in medical school from the first year to the fourth year. So this is why internal medicine is so important. You learn the basic concepts that will help you in any other rotation, if you want to go to any other specialty, you will have diabetic patients, you will have hypertensive patients, you will have hyperlipidemic patient. And if you don't know what that means, you are not going to be successful in any other area. So that's why focus during your your clerkship in internal medicine.
To keep this short and sweet, I'm not an internist. I think the hardest part of internal medicine for me was the attention to detail. By like the fourth day of like, what should their insulin dose be? I was like, I honestly don't care. I need to go back to the ER. And I think the stereotype is, you know, you're gonna pontificate on the meaning of potassium for like 3 hours. So you just have to vibe with it. Biggest tip for you is like, you can be a good internist for 6 to 8 weeks and then move on if you're not into internal medicine. And that's all I'm going to say, because I know you all want to get to the juicy part of exams and prep. So I still don't think Alexander is here, so I can touch this one. Honoring yourself. So I did not make this one because I would honestly say AMBOSS and UWorld are pretty comparable in terms of highest yield of doing questions. And you just have to do questions. If you don't take the time to prep for your shelf and you tell yourself, I'm just going to learn while on the wards, you will fail your shelf, because there is shelf medicine and then there's clinical medicine, and more often than not, they do not align. So do Anki if you want, if you're into it. I personally was not. I just did UWorld questions, AMBOSS questions, and would watch online med videos. Podcasts are honestly super helpful. And I think there's a slide later about podcasts. Do some NBMEs. Really, it's just as many questions as you can do. You're not going to cover every topic that's going to be on the shelf during your clinical time. There's just too much in internal medicine. So next. Practice test. They are worth the investment if you have the money and time. And yeah, take each of them when you can. Review the explanations and questions. And we can go to the next one. So podcast. Emma Holiday has great YouTube videos. There are also like slides you can find on like Reddit. And she basically just reviews the big topics of what's going to be on the shelf for every single rotation, more or less. Divine Intervention is pretty good. He'll review topics pretty extensively, and it is pretty helpful. Dr. Heidield also has really great videos. I think another one to not necessarily help you for shelf, but to help you with the wards would be oh, what is it called? I just looked it up. Clinical problem solvers. They kind of walk through like case presentations and what your differential should be and why you should rule it in and rule it out. And it's really good because, to be honest, if you're not going to be good with clinical reasoning at first, it's a skill that comes with time. And so to be able to walk through that with a podcast is really helpful. And okay, next. Question makes. So this one I made. In my opinion, it's really up to you. What works best for you? I loved AMBOSS for my rotations, and then I use UWorld for step 2 prep. and you'll be exhausted. You'll be so exhausted, and I am. You'll be exhausted, honestly, on your first rotation the entire time. It's not something you're used to. But yeah, if you just use your experience on the wards to prep, you're gonna fail that shit. You're gonna fail that shelf. And you got to force yourself to do at least a block of questions a day. I would force myself to do 40. And I would fall asleep sometimes during those questions, but they got done. Okay, next. And I will hand this off to whoever made this slide.
Now, DCL, do you have a
Sorry,
question?
Oh,
Yeah, I have a question. Thank you. So just going back to the questions, when you were doing questions for like the 40 blocks every day, during the rotation, would you take notes, or were you just doing the questions and maybe like flagging the ones that you were kind of like shaky on? Like, how would you go about it just to kind of like review them and stuff, Because sometimes you just don't want to do questions just to do them, because then it's like, hello, did I learn something?
I would think it depends on your learning style, because I'm a person that I have to hear it, write it, and like do all these things. So like when I was doing online med ed, I would literally write on a piece of paper kind of like what he did. And same thing with questions. The ones that I would miss, I would write it down and just kind of like, and like I color code randomly. It's not like a specific color code. It's just like I needed to see different colors so I can like differentiate it. But it like, hopefully you've learned your learning style at this point, because I think it really depends on you. Like if writing is super important in your like memory process, do that.
In my case, I would create an Anki card. I did use Anki. So I would do like a simple version of that question that I got wrong. And then on the back of it, I would try to incorporate on one timeline, like all different symptoms that I found, so that I could have the full picture together. And then I would try to do it. And I feel like just that process of thinking how they could, everything fits together. If it was just one fact that I just didn't know, I would also make it and then try to review it after. Because I found that just making a list of concepts, to me, it was overwhelming, and I was not going to review it again in a way that I was able to remember it long term.
yeah. And the other thing that I want to add is not just the wrong questions, but the question that you get right because of luck. Because those are, oh, I got it right, I would not know, but you were not sure of why you got it right. So those questions also take into notes and do that. It's important. So here is how to succeed in clinic. I think that a way of enjoying internal medicine is try to arrive to your rotation and always try to find something interesting to do that day. So if this is a patient that you want to learn, that because you will find it. Every ward, every single floor has an interesting patient, and that you can learn from them. So it's very important, because whenever you have a question that the best way of learning, I always think that is the active way of learning. You have the patient and you will never forget about that patient that you saw. If you read something in some place, most likely you will forget, but that patient you will never forget. So that's something to get used to. Like, oh, I have this patient and I will learn it about it. So we talk about early arrival to the rotations. Tell your interns and residents that you want to be active, because sometimes you can go to a rotation and be shadowing. And what is the purpose? No, you want to do the history and physical. You want to present. You want to give, even if your diagnosis is incorrect, you want to give a diagnosis. When you make mistakes, you will never forget about that mistakes. And if that mistake comes in the exam, better, because you know that that's incorrect. So stay late. If needed, not every day, but stay late if needed, because you see that your resident is doing a lot of things, and then you want to say, hey, I found this article. I think that helps a lot the resident and help a lot the team. I found this article. Look, this is what we're looking. Probably this is the solution. And always something in medicine that it's more important in medicine than in other areas is work on evidence-based medicine and critical appraisal of things. So that's very important to do in your rotation. Comes with, as Joseph mentioned, comes with critical reasoning. How you start working on that since that time, that will help you in any area in the future. But I think that in medicine rotation is where you start developing that skills. And most likely the attendants will try to teach you that. If they're good attendants, they will try to teach you that.
Can I add something to that? Because you said something that like really hit home with, I think, a couple med students that I had last year. I think when you start, you guys are very shy, and that's okay. But know that this is a learning experience. If you guys don't do a physical exam, like you're not going to learn. And there were moments where, because a resident is so busy sometimes, like we'll forget, like we'll just do everything and then we'll go and do our notes. And then sometimes my med student's like, well, I didn't do anything. I was like, I'll try to remember next time to like have you do it first. But like while they're listening, take your stethoscope out too and listen with them. Sometimes don't wait for them to like invite you to do the physical exam with them. Just do it with them at the same time. You're not going to know what like pitting edema is until you actually like kind of press yourself. You're like, oh wow, this is huge. You're not going to find that random murmur. I actually had a med student that caught something before me. They're like, hey, can you listen with me too, because I heard something, stuff like that. You try to be engaged, because I know like initially you'll be shy, but try not to be shy.
So I know we're kind of running out of time, but I would just highlight, instead of going through all of them, like probably what would get you a good evaluation would be like showing that you are adaptable, especially if like getting there from the beginning, that you are professional, that you want to evolve, that you want to improve every day, that you're honest about what you know and what you don't know, and that you're curious, that you're like, hey, let me look that up, like what is this, like tell me, let me just take the initiative. That you're reliable. If they assign you to do something, go and do it, and make sure that you report back, that you take initiative. That goes again with everything else, and that you're humble too. That sometimes as medical students we want to do it all and like be in the middle of the action, but sometimes just doing more like mindless tasks that would help the team flow frees up time for the residents to give you more teaching opportunities as the day goes on. And finally, teamwork. Internal medicine is teamwork in a nutshell. So you have to be willing to like work with other people. So if you're able to show that, you will definitely get a good evaluation. So next, I think that's the last one.
Step 2. So the old saying, 2 months for step 1, 2 weeks for step 2, and number 2 pencil for step 3. Honestly, the entire step 2 basically is internal medicine plus a little bit of peds. So like if you study for internal medicine, you're studying for step 2 is my biggest advice on that. Continuous review, it's really up to you. I didn't, but I know a lot of friends that did. Overlap, the family medicine shelf is basically another internal medicine shelf, and the surgery shelf is not as much like surgical management, but more of like how do you deal with acute surgical problems, and you have to think about it from that internal medicine lens if you want to do well on it. Questions. If you have AMBOSS, use their ethics and stats, because you'll get a lot of ethics questions. And then really, however you prep for step 1, prep for step 2. That's all I'm going to say on that this time.
So mindless tasks, I think somebody mentioned it on the little question thing. You'll kind of like see them as you go. So like in psych for sure, like calling collateral, like calling family members, or even like in medicine, sometimes you have to do that because patient's not there, they're altered. So calling family members. Sometimes you need to run and tell the nurse something because you changed management plan, or you need to remove something from the room, or ask the patient, hey, can you leave a urine sample? Like little stuff like that is mindless tasks.
Yes, and just as a final note, internal medicine is around 50, someone said 55 to 60, like 60% of your step 2. So really put your effort, as we have been emphasizing, on like getting to learn this well, because it will pay it off when, not just with the rotation, but later on in whatever specialty, like Dr. Correa was saying, you would encounter these in so many other different ways. I think we'll probably leave it here to not be so much over time. Thank you. Any questions? You can always, maybe we can go back to the email one, so that if someone has any questions, they can get back to us. I think it was.
Can you add mine? Sorry, like legit right now.
You can maybe put it in the chat.
Yeah, the ED was dead, so I was like, let me join.
Yeah, I'll share the presentation probably on the LMSA
Awesome.
website, and then I'll include your email too.
Great.
Thank you so much to all of our panelists for coming. I know you guys are all busy, so it really meant a lot to have you all here and to prepare such a great presentation for everyone. So thank you so much.